In this case, we have a 69-year-old female with a past medical history of malignant neoplasm of the ascending colon, hypertension, hyperlipidemia, obstructive sleep apnea, and no prior history of coronary artery disease that presented to the emergency department with substernal chest pain radiating to her left arm and jaw. She rated her pain as an 8 out of 10, and it was severe enough to wake her up from sleep. She had had her first cycle of chemotherapy with the FOLFOX regimen, which consisted of leucovorin, oxaliplatin, and fluorouracil 2 days prior to presenting to the ED. An EKG showed nonspecific ST-T wave changes, and a baseline high-sensitivity troponin was 21 nanograms per liter, and it trended up to 28 and 31 nanograms per liter at the 2-hour and 6-hour mark respectively. The patient was started on a heparin drip along with aspirin, metoprolol, a high-intensity statin, nitroglycerin, and morphine. An echocardiogram later showed a left ventricular ejection fraction of 62% with grade 1 diastolic dysfunction, no regional wall abnormalities, and a mild mitral valve regurgitation. A left heart cath was performed, and it showed right dominant coronary anatomy without evidence of atherosclerotic disease. Her chest pain was suspected to be related to coronary vasospasms secondary to her chemotherapy agent, and so the 5-fluorouracil was discontinued and the metoprolol was switched to diltiazem therapy. Now more about 5-fluorouracil. It is approved for the treatment of gastric, pancreatic, breast, and colorectal adenocarcinomas. While the most common adverse effect is diarrhea, cardiotoxicity, including angina, myocardial infarction, and heart failure, have been reported. 5-fluorouracil was first reported to cause coronary vasospasms in 2010. The vasospasms were demonstrated by EKG changes that resolved with nitroglycerin and a coronary angiogram, which excluded atherosclerotic disease. But it is important to note that cardiotoxicity can manifest as chest pain with or without electrocardiographic signs of myocardial ischemia. There are several postulated mechanisms to explain why cardiotoxicity occurs, but the main ones are thought to be ischemia and direct drug-related myocardial toxicity. Overall, the prevailing theory supports coronary vasospasm as the cause of myocardial ischemia. So treatment basically consists of stopping the 5-fluorouracil to address the cardiotoxicity and the use of nitrates or calcium channel blockers for the vasospasms. A word of caution: one case report did warn about recurrent coronary spasms that occurred despite discontinuing the medication. In our case, the patient did not have any further episodes of chest pain, and so the use of calcium channel blockers in the treatment and prevention of coronary vasospasm related to 5-fluorouracil is supported.